So Houseworks, we have been around for the last 30 years. We are a leading personal care company. We started our business out of the Boston territory we pioneered the case management model in home-based care. We provide personal care, companion care, and the continuum of care for chronic conditions, supporting those on the home care side. We really take pride in our caregivers. We have retained our caregivers for up to 30 years for some of them. We're really proud of that. We have amazing growth potential in the New England area. We are multiple states, multiple agencies. And since 2022, we've successfully integrated 6 acquisitions, and we covered the full state of Massachusetts with 15 offices: New Hampshire, Maine, Vermont, Connecticut, New York, and Pennsylvania. Next slide. Thank you. So here's a little bit about our journey. Again, we started out in the Waltham area, pioneering that case manager model. And then this is just a little bit of a snapshot of our brands across the New England territory. Next slide. So the one thing I'm really proud to share with you is over the last 3 years, we provided over 45 million hours of care. This care was covered through those that pay privately, as well as those that are eligible for the Medicaid waiver with the ASAP. So we've had contracts with all the ASAPs and the AAAs, and we're really, really proud of that. And again, we have great funding options for our home care clients. Next slide. So again, we are dedicated to the continuum of care, and the way that we do this is through clinical and case management oversight. A case management and RN start each case. We do chronic disease support, which means that we provide ongoing in-home assistance for those that manage complex and long-term conditions. We provide hospice supportive care, and something I'm really excited to share with you shortly is the GUIDE program. This is specialized support for those that live with dementia and their care partners and caregivers. Again, and funding options include Medicare waiver, VA, long-term care insurance, and of course the GUIDE program. Next slide. So today I'm going to share with you a new program. It's a program, it's a CMS program. It's a new model for dementia care, and it's called GUIDE. It stands for Guiding an Improved Dementia Experience. It is a groundbreaking initiative launched by CMS, and it focus was for care for people with those living with dementia and supporting their family caregivers. So it is a national model. It offers structured team-based dementia care delivered in the home or in a community. It's designed to reduce caregiver burnout and avoid unnecessary hospitalizations. Participants receive comprehensive services, including care coordination, respite services, caregiver education, and access to community-based support. So who's eligible? Patients, they must have a documented diagnosis of dementia, any stage, is enrolled in traditional Medicare, that's A and B, no Medicare Advantage plan, unfortunately, is not currently on hospice or resides in a skilled care, long-term care community. Short stays are fine. And VA, dual eligible Medicaid patients, memory care, and palliative care patients can be eligible. Next slide. So here are all the benefits without the burnout. So they have their own dementia-trained nurse who reaches out for regular phone, video check-ins to monitor health. There's 24 access to your care team, 72 hours of paid respite care provided annually. And what's really great about that is it renews every year. So once a patient is on the GUIDE program, it renews every year. And another way to think of the 72 hours is it's 18 days of 4-hour shifts of care that can be scheduled throughout the year. Care coordination with existing doctors, specialists, medical equipment, medical suppliers, etc. Medication review, family support and education and coaching, and management of other chronic conditions, and referrals to community resources, and more. Next slide. Thank you. So again, what's included? Personal care plans tailored to medical, behavioral, and social needs, care navigation, and the 24-hour support line. The care navigators we partner with, for them, we provide, Houseworks is a care provider for them. So again, for 72 hours per year covered by Medicare, and it renews annually. And why does this matter to families? We could probably do a whole training on why it matters. The caregivers really get the help that they need, not just instruction. Guide really provides hands-on support, not just referrals. And I think it's stability for loved ones over the holidays. We were so pleased to be able to provide some of this care for respite where families were having holiday parties and functions, and whether the patient was coming home to join in those festivities, our caregiver went with them, or they were staying in their community where they lived. That's what we did as well. And it's really peace of mind for families. So at Houseworks, our longevity, clinical oversight, and participation in the guide program, it really reinforces and reflects our commitment to be a true partner in the continuum of care for families. And at Houseworks, we feel care doesn't end at discharge, it continues at home. If you'd like more information on the guide program, my contact information is there. Very happy. And I just want to thank you all for the important work you do every day to support patients, families, and communities. Thank you so much.
Thank you, Celeste, for that overview and your support of the Case Management Society of New England. We absolutely appreciate it. And
Thank
for
you.
that overview of the guide program. That sounds like we need some more education on that.
Absolutely.
I'm going to pass it back to Jean, who will introduce our next speaker.
Hi, everybody. Hope you're hanging in. We saved the best for last. I'm teasing. Everybody's been fabulous today. I have the pleasure of introducing Dr. Ellen Fink-Samnick this afternoon. Is it afternoon yet? Almost. The last speaker of our first day of our conference. And I just told Ellen that I met her or heard her speak probably 10, 15 years ago, and I'm still using the model that she gave me, the 5-finger model. So I'll tell anybody about it if you'd like to know. Dr. Ellen Fink-Samnick is an award-winning industry entrepreneur whose focus is on professional case management, health equity, interprofessional ethics, quality, and trauma-informed leadership. She is a content developer, professional speaker, author, and educator who is a faculty member, academic advisor, the culminating project lead, and IRB coordinator for the Doctoral of Behavioral program at Cummings Graduate Institute of Behavioral Health Studies. Dr. Fink-Samnick is a member of the Professional Case Management Journal editorial board and is the editor of the journal's Heartbeat of Case Management Department. She also serves in national leadership and consultant roles, including the chairperson for CMSA's DEIB Core Committee. She's also on the board of directors for the National Transitions of Care Coalition. People describe her as professional case management's moral compass. And that's a weighty assignment, but she's very equal to it. She's been inducted as a fellow in care management by the Case Management Society of America. She's a prolific writer, as we said earlier today. Her 5th and her 6th book were donated by her, and they'll be given away at the end of Ellen's lecture. So thank you, Dr. Fink-Samnick, and she's going to present on navigating the social determinants of health in this healthcare environment. Thank you. Welcome, Ellen.
Well, thank you, thank you, thank you. Good morning, everybody. So I hope, first of all, thank you, Jean. And you suddenly start to feel a little vintage-like. You know, when people say they heard you talk 10 and 15 years ago, and I remember that five-finger model. We'll leave that be for now. But boy, have things changed and shifted since then. It is always my honor to be with CMS of New England and talk about a chapter that's continued to shift and change and evolve with the times. And amid such interesting times, I do hope everybody's warm and dry and toasty. It kind of makes the graphics in my opening even more profound. So, with that being said, I'm going to shift a little bit and get started. But I want to start here. Change really is an absolutely fascinating concept, and one, as if I wasn't aware of it enough already working in our industry. Last September, my better half and I took our first vacation in 6 years, and don't let that be said for one of the people that's a poster child in our industry of always prioritizing our resilience and our self-care. But we went up to Alaska. And what you see before you is Mendenhall Glacier. And the reason I'm showing this, so between 2007 and 2011, so in a really relatively small period, the glacier lost ice comparable to a football field each year as pieces of that iceberg just ended up in a lake growing and growing and growing. And what you see on the left was a picture from about 2011 even. The picture on the right with yours truly and my other half was taken in September 2025. And by that point, the green area, that beautiful green area on the left, was gone, totally underwater. And the lake behind us was over a mile in diameter, and that was caused by all of this melting and the impact to the area, to the economy, the environmental structure, the livelihood of the region was major. But what happens when a shift like this occurs in a matter of months? Well, welcome to our world. And this is what we've been dealing with. This is what, well, we've been seeing coming for a while with the ongoing advancement of so many fragile, vulnerable, complex patient situations, ongoing exacerbation of social drivers of health, social determinants of health, social barriers to health, health-related social needs, social risks, psychosocial factors, social determinants of well-being, and countless other names and terms by which we continue to refer to the stuff that most impacts the safe transition of our patients to where they need to go when they leave the hospital. Ron Hirsch and I have talked about this for years. And 40 some odd years ago, when we were both entering this wonderful healthcare industry and both at hospitals in our respective training and initial jobs, we faced these issues. But at this point, we're seeing the ongoing assault of very rapid changes in federal requirements, SNAP requirements, disappearing Medicare Advantage plans, and a lot of unknowns about funding, Medicaid cuts, and then those quality measures that we waited so long for, those coveted quality measures, now just about gone. And we're going to talk about all of this. Now, for many, it's felt overwhelming. Yay to the innovative programs you've so far heard about in today's session. But the other piece of that I continue to value is just that case managers are not just anyone. We are wired in a way that forges us to manage these stressors, manage these changes, deal with the ongoing flow of information and the changes it means for our practice, and continue to take that knowledge as our superpower to evolve and develop new programs. So let's chat about what's changed. Let's chat about the facts and kind of define some collective action, if you will, moving forward. And then we will send you off for the rest of your day today. So here's what we're going to talk about. We're going to chat about some of the shifts and regulations, the legislation and funding. And I know you need a scorecard. Just when you think you have it down, it changes, and more and faster than it ever has before. And of course, we're going to chat about some of those ethical, legal, and regulatory moving parts of these shifts for the workforce, what it means perhaps to the settings that you're in. And then, of course, look at how our various established resources of guidance support our actions, support our program development, and continue to serve as our professional anchors, if you will, in such uneven times. Typical disclosures and disclaimers. I know this crew has seen them, particularly if you've seen any sessions that I have done. But for those that are new to a space that I am in, they're important for you to know. First, I may mention certain products, topics, refer to articles, know several things, that all the material I'm presenting on, all the research, all the data is all from scholarly articles, and all of them are cited and attributed in this session. Any of the products that I refer to, talking about Facebook, LinkedIn, any online portals, etc., are only being presented for the sole purpose of example. I get nothing for saying them, all right? So just to be aware of that. The other thing is the topics, the presentation. I think some of the ongoing challenges with what words to use across these populations is challenging to the workforce, and dependent on the state and the region you're in and the populations you're working with, it can be even more challenging and elicit a lot of emotions. I respect that immensely. First and foremost, my goal is always to educate and provide some additional knowledge. I tell that to everybody, every student and every practitioner. How you use that, how you take it, how you let it validate or advance your own practice, that's going to be up to you. That's going to be up to the organizations you work with, the policies that you subscribe to, and your own internal intrapsychic processes. All right, let's get started. I know I've got just about an hour, maybe a little less, to allow for questions. I know I'll probably start getting some pushes from the chat. These slides are available. There is a fair amount of information on them. And you'll notice I'm not a slide reader, folks. Never have been, never will be. So I'm going to be talking to what's on the slides, but then certainly afterwards, if you have questions, points for clarification, you know the drill. You'll tuck them in the chat. We'll try to address as many of them at the end of the session. And those that I don't get to, just email me or reach out somehow, or reach out to the chapter and they'll get the questions to me so that we can get your answer set. So let's look at this kind of from a population health perspective and what's happening out there to our populations. So housing. The current schema is pretty wild when we look at housing insecurity in general. We've got people that are solely priced out by high rent and limited housing alone. And that's across every socioeconomic strata, if you will. 74% of extremely low-income renters experience some severe cost burning, meaning they spend over half of what they make, and sometimes that's very, very limited income, on rent, which leaves very little for anything else. Only 35 available and affordable rentals for every 100 of the neediest renters. When you think about it, that's incredible competition. And for more vulnerable, populations, the rates of homelessness continue to rise. We have the point in time survey, which annually is done January, February. The last one told us we've got roughly 750,000 people out on the street at any given time. 7% of them were veterans. And yesterday, I happened to, and way too late to add it here, looked at the latest Blue Star Families Report, and that's done every year for military members as well as veterans. And it looks at how these folks are doing in the context of the social determinants of health. I think about 3 or 4 years ago, maybe, they decided to align the report with housing, with childcare, with income, with and employment, with education, with access to care, and the other areas that we know specific to the SDoH. And it still continued to talk about 35 to 40% of that population, particularly military members, really struggling to find appropriate housing, to make use of their basic housing allowance, and know that they have enough for food, for childcare, and all that goes with it. Moving on, when we look at the LGBTQIA plus community, ongoing struggles, particularly with safe housing. 40% of youth struggle, more than 50% of adults often finding themselves between these safe spaces to be. Patients with disabilities, another ongoing issue at 30%, and families of all in general is a big issue. And when you think of them on the street between transient and different sorts of housing, hotels and family shelters, we're looking at 40% of all homeless families, and then 50% with children under the age of 5. This presents major challenges, obviously a major disruption in care, fragmented care, and it's growing everywhere, every state, plus the District of Columbia, which, as I often say, continues to strive to be a state. Now, I love nice graphics and I love nice tools. In the interest of time, I'm not going back and forth online, but certainly this resource is a wonderful one. It's the End of Homelessness site, and it has a map. It's interactive. I do provide the reference for this at the end of the presentation. And it shows the current rate of rents per region. And so what you're seeing before you is the snapshot for Massachusetts, roughly $683 for rent. I think that's kind of low. And if I could see many of your faces, you might think it's low too. You know, and yeah, I'm sorry. Average rate of income is 683. I'm sorry. And then 1757 for a house, to rent a house. Knew something was off. This is not enough. Monthly minimum wage, medium rent, 1 bedroom affordable, and that's the average. Something's very wrong with this picture, and I would venture to guess for your region, it's just as bad. Now, I know this graphic's kind of busy, but this is a scatter plot that shows you what it looks like in every state around the US. So if you look on the left, the higher the average trend, the tougher it becomes to stay housing secure. And certain states clearly have bigger challenges, right? As the rates of the pricing goes up, and you'll notice, you know, certain regions are going to be higher, especially New England, especially the Northeast. I know we've got Virginia, my adopted home state. We've got Massachusetts, also part of, let's see, Massachusetts is in the yellow. So look at this, guys. I mean, I'm going, look at this, and I'm pointing, you can't see it, but the upper left quadrant, higher homelessness rates, higher medium income, lower homelessness rates, lower median income. It's not balancing is the bottom line. And again, you can look these up and share them on their own. All right, so let's see how awake you are after the long day. This is a little poll for you. The fastest growing homeless poll nationwide, and in the interest of time, you could tuck it in the chat. A, persons with disabilities. B, persons with severe mental illness. C, seniors who are medically fragile. D, families who are victims of intimate partner or domestic violence. Take 30 seconds, toss your reply in the chat, and you can just put A, B, C, D, E. Ah, there you go. I love you guys. Dun, dun, dun. Oh, what a mix. I love it. Yeah. So some of this is really going to be dictated by where you live. Okay, we'll give everybody another 10 seconds to get something in there. I see a lot of you picked between B and C. Okay. Dun, 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 dun. We're gonna do a Jeopardy tap, and seniors who, whoops, are medically fragile. And that is the biggest and fastest growing population right now. Adults over 55 who are medically fragile, medically vulnerable, may have one or more chronic illnesses. They are housing insecure at rates of 50% or more of the population. These are the folks that have the highest rates of comorbidities. They are increasingly frail. And the question of how you assess that and measure that, well, I'm going to give you something for that. The impact of medical debt for these persons is massive. And we're going to talk a little bit about medical debt, financial toxicity, the way it's depleting savings at a rapid rate, and it further increases the risk of homelessness, housing insecurity, increasing those SDoH, whatever words you use for that acronym, and frankly, mess with the health, wellness, and successful outcomes of our patients. I feel like that should be the end of the discussion, but we know there's more with it. So I don't know how much folks are familiar with this. It's Freeze Frailty Index, and it's a pretty interesting tool. It looks at 5 issues. It looks at the loss of significant weight in the past year without trying, right? And we know that could be related to pathophysiology, psychopathology, psychosocial health, all of the above. Level of fatigue, level of feeling no energy, totally depleted, unable to really get to take care of the things they need to, get to the pharmacy if they need to, get to a market, get to a medical follow-up if they don't have sufficient Wi-Fi or there are digital health literacy or tech equity challenges. Their overall endurance and activity is pretty much depleted. Isolation is starting to ramp up. Their weakness is a factor. And, you know, some models like this one still uses adjusted for sex and gender and BMI, which BMI we know is not always the most accurate indicator, but it also looks at how fast someone walks. And I'm not talking about a 6-minute walk test or anything like that used for, you know, COPD, but just how fast their gait is, whether or not they can get to where they need to be. And 3 or more of these criteria for a person indicates they're frail. And this continues to be one of the seminal models out there to denote frailty that's often not even used, but I share it with you as a mechanism, as I like to do, of assessment that perhaps for your programs might be a benefit. So let's move on to health care costs. And, when we're talking about healthcare costs, well, this is a challenge. Probably about 50% of the adults out there say they cannot afford healthcare costs. And this is a fairly new report or article, if you will. It's an issue brief that came from the Kaiser Family Foundation Peterson Fund. And they do some phenomenal, very timely reports on all that's happening in the return on investment, fiscal focus realities of our populations. About 30% say that they or some family member in their household had problems actually paying for their healthcare in the last 12 months and had to go without it. 20% of those people totally said, nope, not taking my meds, can't afford them, can't access care. That's the upshot. And the challenge of how you manage it is what is leading us to a very interesting intersection that's appearing across the industry. We're used to talking about medical debt, and I've been hearing about medical debt since I've been in healthcare, and that's a lot of years. And I know many of you have as well. But now we're also looking at another element, and that element of financial toxicity really accounts for that whole person view that we are looking so keenly at in the context of care, because that also impacts health outcomes and one's willingness and motivation to care for themselves, the family's ability to care for and be there for the person and be responsible and consistent caregivers. There's a fair amount of stress that results from that financial burden which people have, and it contributes to higher levels of health well-being and certainly outcomes. Yeah, of course I got a study for that. And it's a brand spanking new one. Would I come to you with something like that without a study? Yeah, 12,000 people was the N. And so what this tells us is a lot of people suffered from medical debt. More than 10% were dealing with heavy duty costs, big impact to family income, catastrophic cost burdens that were at least 40%. So imagine having close to 50% of the money you earn after taxes and excluding food going to your health care, and then had to forego care or had to have some other impact on the family overall. Well, yeah, here's what we're looking at. Here's what we're looking at. 1 in 4, so a little over 25%, so 26.7%, totally said, can't address care, need to delay care. We know what happens with that. They end up in emergency rooms with higher intensity, higher acuity, longer length of stay, higher healthcare utilization. Over 50% who died incurred incredibly burdensome costs that went to their estate, their families, and all of these issues. I know I'm not telling you anything you don't know, but it's a solid reminder. Solid reminder. Higher rates of chronic disease, increased hospitalizations, patients who do not have or insufficient insurance, and lower income were the highest cost burdens, and why we are fighting to be so proactive with the care we provide. What's another big issue right now? Well, here's a really, really big one. Anybody that has followed or utilized the certified community behavioral health clinics, these are major, major resources that meet the needs of our patient populations within communities, serving roughly 3 million people. Nobody is denied care at a CCBHC. Some are funded through federal funds, grants and such, many within Medicaid, and they are at considerable risk. Now, these populations serve the most vulnerable of the communities, and they are an important stopgap, if you will. 76% reported that referrals to primary care increased simply by patients coming in having a visit, and then being linked by the case management and care coordination teams within the CCBHCs, or the models that often have support these programs through visiting nurse. In New York, there have been some very successful projects with this, aligning health plans as well as Medicaid and such. 30% reported that the referrals increased by 20% or more. Not too shabby for a patient that often is known by many. Yes, I'm going to use the words not compliant. I hate that terminology, but patients who have a harder time adhering to their treatment plan and engaging in care. They are complex. More than 50% of these patients struggle amazingly with housing issues. 76% have at least one or more overlapping chronic health issues, usually 2 or 3. And, when we look at the fact that we might lose this resource when we have CCBHCs involved, 73% less hospitalizations, 40% less homelessness because they're able to step in and help mitigate those gaps, less than 60% time in jails. So before folks stop and judge the populations, you got to stop and look at the data. If any of you were at CMSA, there were a number of presentations actually on this topic. I know that you can still view them on the ERL site where all of the content lives for sessions with CEUs and things like that. They're very informative and very timely on this issue alone. So changes in Medicaid, how long you got? I know we could be here forever. I will try to be quick. But here's what we're dealing with, and we don't have a time to hit every nuance for every state, but here's what we're looking at. Here's what we're looking at. So all Medicaid recipients face mandatory eligibility reviews every 6 months. You think this is going to create somewhat of a little heavier burden? The states must implement outreach and verification using those 1115 waivers. All of the enhanced federal medical assistance programs are going to expand Medicaid and immigration starting October, which we're, coming, we'll get here quickly. Only U.S. citizens, lawful permanent residents, and Cuban Haitian entrants remain eligible for Medicaid. We've got some big changes coming. That's going to impact the bottom line of every single place where every single case manager works and across the transitions of care. And then, of course, yes, we have these work requirements, which have been quite a focus over the years. So we've seen a little bit of change. The federal law expanded the work requirements recently, and for ABAWDs, just what we need, another acronym, able-bodied adults without dependents, and we've got a whole slew of new categories. Adults have to work or be involved in some training at least 80 hours a month to get benefits past 3 months. Caregivers are going to be impacted in ways they never were before, particularly parents or caregivers with children who are over 14. Previously, they were exempt. Now they're included. This is going to dramatically change the landscape for this population, and the exemptions are narrowed. The only exemption for veterans, homeless, and foster youth were reduced or eliminated in many areas. So those of you working with these populations or more of these populations or less, get ready. Get ready. And I know I'm eliciting questions and comments, and we're not sure how this is going to play out. And many of you are in acute settings where you barely have time to screen and say hello to a patient, let alone focus on these issues. But those of you that are outpatient, home, community-based organizations and providers, We'll be dealing with this. And guess what, inpatient folks here, you're going to be dealing with it when patients come back in. SNAP requirements. Nope, not a slide reader. But here's the upshot. Here's the upshot. We know there will be changes in SNAP. And here's some interesting information for you guys. 1 out of 6 people, and when I say you guys, so my friends in New England and Massachusetts, 1 out of 6 people receive SNAP alone. 18 states have sought bans on some of the SNAP benefits, and that includes a slew to really encompass food restrictions, because SNAP purchases that focus on really sugary, unhealthy foods mean higher healthcare costs, higher healthcare utilization, potential for increased hospitalization and visits. So, Arkansas, Colorado, Hawaii, Iowa, Idaho, Indiana, Louisiana, Nebraska, North Dakota, Tennessee, Utah, Virginia, West Virginia. Those states have sought bans. Iowa has the strictest rules at this point. So anyone on from Iowa or who has patients that reside in Iowa, banning soda, candy, and other prepackaged foods subject to the sales tax, chocolate-coated nuts, sweet popcorn. Can't use it for SNAP. Florida and Texas will start their bans in April, South Carolina in August, and Missouri in October. Oh, that'll make for some fun presentations during CMSA National in June. The bans across New England, they vary. And it's going to keep changing. But this does impact the food that people have access to, what they drink, how they eat. And, the hope is this may help the situation, but we're still not sure. The verdict's out yet. So Massachusetts actually has a very nice eligibility screen for SNAP. This is not an online graphic, if you will, or slide, but I did want to give you a snapshot of the screening site. Other states do as well. It essentially asks, who's in your household? What do they need? Do they have any physical or mental disabilities? And what's the gross income? It's pretty down and dirty, and they're using this as a quicker way to screen. So it's interesting. We'll see more of these across the states, and hopefully it will enhance the health of populations and access to care, though not everybody is clear about that. Wait, there's more. So let's talk about the quality rollbacks. I know that we have a number of case managers in varied roles, have a varied scope, that are doing quality improvement, that are doing utilization management, that are focusing solely on quality measures. Well, CMS did remove 4 measures from their hospital inpatient quality reporting. And I know Dr. Ron Hirsch is on, and this is one of his favorite topics. Because if we're not looking at quality, well, how do we know that the outcomes will transfer and what the factors are? So 4 of the measures that everyone was very excited about 2 years ago, I think most people were excited: hospital commitment to health equity, COVID vaccine access for among healthcare personnel, and screening for social drivers of health, another one of those terms, and screening positive rate for social drivers of health. Now, even though this guidance has been withdrawn, the new 1115 waivers that include health-related social needs services will continue to be reviewed case by case. Can we make things a little bit more confusing? And some of the existing approvals of the waivers will not be restricted. Spoke to some folks from CMS a month or so ago, and what they shared with myself and some other folks who were in the space, including CMSA's past president, Dr. Colleen Morley, who I know is joining you next week. they're really hoping to reduce some of the duplication of measures, streamline reporting. And they also talked about the 4 measures on pediatric and prenatal immunization status from 2026, and the child and adult core sets are going to be gone. They feel that there wasn't enough coordination among the benefits, and that there was a lot of duplication, and that made it more difficult for our workforce rather than easier. So while it seemed like they're cutting, the feeling was they were really trying to make it an easier process that looked at the key measures from a unique lens, and thus would make the reporting of those measures and the dollars in the intervention for those measures easier to access. We will see. And no, Dr. Morley and I got the names and contacts of those folks that we met with, and we really will have to see what this looks like. Along with that, I know folks, especially in our case management world, have really followed the growth and evolution of innovative programming across CMS, and especially their Centers for Medicare and Medicaid Innovation. I've talked about it. Tiffany Ferguson, who I know is joining you in a couple of weeks, along with Dr. Morley for part 2 of this. We talk about this often. So unfortunately, we lost 4 models. We lost the Maryland total cost of care model, the primary care first model, and the dates you see were the run dates that they were going to be out there for end stage renal disease treatment choices, and the Making Care primary model, which is devastating to me, because I've done a lot of work and research on this for populations, along with many of the CMS fellows. We crafted some great articles for you all and position papers on this model, knowing the difference it would make also to our programming and our ability to be more proactive for these populations, and gone. There are reductions to the integrated care for kids model expected. And however, there are going to be more, because as we have out with, we have in with. We got new models. We got access, which is the effective chronic care with effective scalable solutions model. You gotta love a snappy title. You gotta love a snappy title. We have the ahead model. We have the balance model. And the balance model, yep, it's also got a fancy name: Better Approaches to Lifestyle and Nutrition for Comprehensive Health. Well-intended name. We have the GLOBE model, Global Benchmark for Efficient Drug Pricing. Drug pricing is a major issue. It's an issue for providers and practitioners and patients, and they have not been able to mitigate that one. We'll see what this program yields. The integrated behavioral health model, still hanging in there, still alive and kicking. The LEAD model, which is the long-term enhanced accountable care organization model. The TEAMS model, still out there, transforming episodic accountability. The transforming maternal health model, as well as the integrated behavioral health model, as I mentioned. And I would be remiss if I didn't mention this one, the latest, greatest. So the rural health transformation model. I know a number of you work in or have patients and families, clients, members, consumers who reside in rural regions, or you work for federally qualified health clinics, community health centers in rural regions. So this is amongst the newest funds out there. A lot of dollars, and a lot of dollars to go across 10 years and rural states, but ultimately every state who applied for won an award. What does that look like? Would I make this up? Heck no. Here's the impact. So the average was 200 million. And if you look across the states, and it's hard because I'm not in front of you, and I can't break out my laser pointer because only I'll see it. But you got New Jersey on the left with 147 million, and then on the right You've got Oklahoma, Montana, California, Arkansas, and Texas, who got 281 million. That's a lot of funding. DC, ironically, in the US territories were ineligible, but this is big dollars. Now, what's going to happen with it? That's a presentation in and of itself. The programs that will be yielded from this, where the dollars will actually go, how much will go to infrastructure, how much will actually go to providing care and services. It's going to be fascinating because by now, those of you that have heard me speak know all of this is great. But until I see the true fiscal and clinical and administrative outcomes, I'm not happy. I'm not happy. All right. I'm being mindful of time. We've got about 25 minutes of content, 25 minutes of time, and just the right amount of content. So let me keep moving along. And again, I already see questions and comments appearing in the chat. So I'm going to keep this rolling. And yes, knowing me, dare we dig into Medicare Advantage shifts? Well, how do we not? The changes for 2026 are going to focus on greater cost controls. From what we understand, improved drug benefits, a $2,100 Part D cap, stricter rules for the extra benefits. Some plans seeing insurer pullouts, right? We've heard a lot about this with high numbers, high incidence of providers going, no, this is too expensive. We can't do this. We can't do MA in this market, reduce service areas, tighter chronic care benefits. And guess what? We know the prevalence of chronic illness and the whole person view that comes with it. And yeah, holistic with a W, not an H, because we're trying to bridge the gaps and holes in care, right? So diabetes, cardiovascular conditions, neurological disorders, arthritis, rheumatology, it's massive. The plans have to be able to provide some perks, and we're going to see a lot more cost caps, particularly on insulin, administrative requirements to premiums. I mean, how long you got? We could stay on this slide only. Greater cost sharing. It's going to be fascinating. We also know there's been ongoing reduction in the plans. Those that are out there will see increased limits on non-related health items, alcohol, tobacco, cosmetic surgery, funeral costs. Enrollments in the special needs plans for chronic conditions are continuing to grow and rapidly. And that's because the populations haven't gone anywhere. We can continue to call these populations anything we want. Even distinct populations was how one regulatory board now refers to these communities in their CEU requirements. But ultimately, they are still the populations that we need to pay the most attention to. And case managers become handcuffed without being able to link them to appropriate benefits, right? We know that. We know that. And they'll keep coming in to visit us. And not because they love us, but because they have to, or their health condition brings us in. So wait, you think I'm done with this section? No, because I'd be remiss if I didn't mention this. So how does this play in to the topic at hand? Well, it is suggested that defining professional degree status is a strategy to mitigate student loan debt, because there are a lot of people from homes with the lowest socioeconomic status that really rely on loans to be able to advance their education in graduate programs, doctoral programs. Well, I know that our case management community is well aware of the ongoing challenges to access those programs because the loans will potentially be limited and dramatically. Now, this was a whole big hubbub a couple of months ago where it suddenly came out that nursing was never a profession. There were 10 I'm digress. I'm moving a little too fast here. And that's because it's where my brain goes. But let me start here. 1965. There was a federal law that defined a professional degree. And there was a CMSA blog that was written on this topic, a couple actually, back in December. If you haven't read them, they're still up there and living. And a professional degree was originally defined as one, and I'm reading, that signified completion of academic qualifications and advanced skills beyond the bachelor's level. And there was an original list of 10 degrees: dentistry, veterinary medicine, chiropractics, law, medicine, optometry, osteopathic medicine, pharmacy, podiatry, and theology. Anything missing, folks? Yeah. Nursing was missing. Social work was missing. Counseling was missing. PTOT, speech, vocational rehab. Many of the professions that are part of our valued case management hood and our professional case management credentialed hood. This funding really has the potential to harm workforce development, counter equity efforts, does not support education, devalues recognition for the professions that are heavily made up of women, racial and ethnic members, and serve marginalized communities. I'm just getting warmed up, and I know our time is limited, so I'll stop it there. But please know that this is not a help. And we are waiting desperately for a opportunity to push back, to advocate for this funding plan to not go through. We are waiting desperately. We thought by the end of January, I thought maybe by the end of this presentation, there would be a link I could share with you about the appealing of this decision, because it's not formal yet. Know that we are watching it. I'm watching it. CMSA is watching it. I think every professional association is watching it. NASW is watching it. The ANA is watching it, et cetera, because everyone believes this is not going to help patients. This will further limit the workforce. One more burden for the workforce to bear that really will threaten its resilience and ability to best respond and compromise our organizations and their ability to provide quality care even more. So know to be watching for more information on that. All right. So let's look at what's happening in the regulatory world. I want to keep moving forward. What does this mean for us in case management? How does this intersect and play into how we operate in terms of our professional obligations and requirements? Well, a couple of things. So, from a regulatory standpoint, CMS shifted slightly in 2025, as did Joint Commission. Both had imperatives to deal with the populations more compromised than others. They've both been renamed. They've both been reformulated. CMS, their framework for healthy communities, has these 5 tenets, really committed to expanding data collation, looking at how they can close the gaps in care, building capacity of the workforce, still focusing very much on language literacy, health literacy, digital health literacy, improving care for persons living with a disability. I've had conversations with folks from CMS. They remain very committed to this effort. Many of them have been part of CMS or other programming over the last decade and continue to forge that mission. So I'm going to be optimistic. Joint Commission, which has a fancy new logo, the only constant is change. They have their excellent outcomes for all accreditation. I am sorry, guys, I gotta say it still sounds like the Lego movie. But in all seriousness, this is the latest formulation of this program. They focus on really prioritizing optimal outcomes by leading and setting an example, looking at how the certain pillars of care fit within each organization's strategic plan, collaborating, right, from a community perspective so that the service needs of that community are clear, real true population health imperative, and they get a big clap for that. Looking at distinctions in patients' outcomes and different methodologies to improve care and treatment and service across all patients, ensuring attention to those needs and continuing to utilize the data. What about accreditation? Well, that is changing too. NCQA, well, remember those health equity measures? We now have health outcomes accreditation and community focused care accreditation. Goodness gracious. For those that remember, we used to have the health equity accreditation program. That is what shifted to become the health outcomes accreditation program. Still, the community-focused care accreditation program really looks at whole person care. So all of those premises are still there. They just changed names. Health equity went out. Health outcomes and more global views at health outcomes for across populations came in. The goals, the data types, the focus of each program are clear on this slide. They're also clear on the website. And the goal is continuing to move along this process. NCQA also still does have their case management accreditation, which has been unchanged and also drives these processes. You can certainly look further on the website at all of them. Now, what didn't change that much? Well, URAC, who had just put out their health equity accreditation earlier this year in concert with the National Minority Quality Forum, said, nope, as of this point, this time, 12:20 p.m. Eastern Standard Time on Saturday, January 24th, 2025, it hasn't changed. I can't be responsible for what happens in the next 10 minutes. And I hope you're laughing because we can't. Right now, they still have their health equity accreditation because they recognize that some 70% of about 200 healthcare leaders agreed that this remained an important topic. They surveyed them, yet only 10% had some formal process to address any level of culturally or linguistically appropriate care. That's mind-blowing. None of this went away. None of the populations went away. I know I'm becoming my animated self, but what they did is they set this accreditation in place with the National Minority Quality Forum, and it continues to be there. We'll see how it rolls. Our individual codes, even with the changes that are going through, they have not changed the language. ANA put out their new Code of Ethics in 2025, continuing to focus on the inherent dignity, worth, and unique attributes of each person. NASW, the same for their Code of Ethics, nothing changed. CCMC, CDMS, 2023. Guess what, folks? Nothing has changed for those of us that are accredited through these entities. And still have not changed. And yeah, you knew I was going to put this up there. CMSA, their standards of practice, all of the standards of practice for that matter, are hallmarks of our practice and anchored by standard E, right? So we have resource management, we have client assessment. They clearly speak to how we look at whole person care. How every employer needs to be always prioritizing access, choice, and cost for the patient. Health equity, quality, and safety should also be aligned. And we need to be able to document that and make sure that our assessments are comprehensive and looking at the person in the scope of their space across physical, psychological, social, environmental, and spiritual domains and their setting of care. And all of these other standards are as relevant, especially advocacy. Because first and foremost, we are always advocates for our patients, even when our beliefs and mores differ from theirs. That's where it gets tough. And I know that's a presentation in itself. I'm not going there today. But know that patient advocacy always remains one of our primary obligations and hallmarks. It also means we partner with patients and their families to access care. We don't do the care for them. We don't provide it for them. I know sometimes it feels like we do, but we support them on their journey. And now we're even pulling in things like competencies in the education realm, counsel and social work education as their competencies. Nursing credentialing entities have theirs, all still focusing on these factors. So none of these have changed, folks. None of these have changed. Those for ANCC haven't changed, and the American Colleges of Nursing. In fact, they're even stronger. They're even stronger. We're still looking at intersectionality and all the factors that shape a person's existence, except I know, I get it. Within acute care, you've got a finite period. You cannot fix it all. And primarily, you're looking at what you need to do to transition them from that space in a requisite period of time and hope they're not coming back. I can see my friend Ron Hirsch laughing at that one. Hopefully, and if they are coming back, they're coming back in a limited time span. So, how do I wrap up something like this? Well, let me do it this way. Let me give you a couple of lessons and a couple of resources and then a couple of closing thoughts. I think that will best serve our needs for today. First of all, let's remember what case management is and isn't. We gotta stop having an us versus them mentality. We're all, as case managers, independent of your certification, whether a CCM, whether an ACM, whether a CMGTBC, or any other credential, those being the three primary exam-based ones. The magnet status ones still continue to be CCM and CMGTBC through ANCC. But they're all about collaboration. They're all about respectful communication. They're all about how we step in, how we work as a team with every practitioner and provider as we can. I know some of those are tougher. They're not all like Ron Hirsch. They're not all like my father was, where they believe in communicating with each other. They're not like the physicians that I mentored and taught about case management and still continue to dialogue with about how do we partner and provide the best care for the person in the moment to get those best outcomes. How do we work with others to make sure we are going to close the loop? And I'm sorry, folks, closed loop is not only about technology, because even the best technology platforms don't always close the loop unless they're assessing and engaging with that patient. I'm a big proponent of technology, but we need to be able to do those closed loop referrals in a meaningful way. We need to make sure we advance programming. So Medicaid waivers, 1115 waivers continue to be here. I pulled this as of December 4th because the slides needed to be in. Continues to shift, but these 1115 waivers under Medicaid are still there, and this breaks it down. The social determinants of health, social drivers of health, and other select plans related to care. Not as many of them as we'd like, but still a fair amount. Some 30, 37 of them, and there are 34 still pending. This is funding that still supports advancing critical programming for patients that have. And we're going to have to see how some of these SNAP benefit shifts really play out over time, how work requirements play out over time. They were fought the first round in 2016 and 2017. I think at that point we had Arkansas and Georgia were the only two states that advanced them. And even now, some of what I'm seeing is already noticing hiccups and problems and case-by-case examples. Whenever you start to see, oh, we'll evaluate them on a case-by-case example, it's not going to end well for the benefit, and it'll be a need to change it. Medically vulnerable people shelters, MVP programs. These are biggies, and they're growing. across the country. There are a number of them. They really promote safety for persons that are housing insecure. They provide a lot of great comprehensive services. They really target a lot of the senior population, 60 to 62. They really do a nice job with integrated care, so medical care, primary specialty care, as well as behavioral health with trained teams. They promote patient self-efficacy, and because their goal is to get them out of those and into permanent housing. They also have big programming, and oh, you think I wouldn't give you more resources on these? So these are a number of model ones across the country. Catholic Charities has their Healthy Housing Initiative. I actually know some of the folks involved with the planning of it. There is a directory through the National Healthcare for the Homeless Council. It's a medical respite care directory. It's pretty accurate. I obviously am not going to give you anything I haven't looked at and vetted myself. The Road Home is another of those model programs. The Havens Project through Trinity Health, their Safe Havens program, and obviously sites like 211 and Find Help. They provide some good intel. We're still really watching the funding machine. And so I always tell people, go on to CMS, and in fact was advised by the assistant director of CMMI that people should go on. They should apply to get email updates. So scroll down, I'm giving you all the instructions to watch for those notices of funding opportunities. Pick the areas that interest you. You could pick all you want. How many of you didn't know that there were 12 new models out there that are waiting for you? Many of them involve care coordination, support for technology infrastructure, all sorts of program enhancements. Many address chronic health, chronic illness, vulnerable communities. The social determinants of health, social drivers of health, the populations that have less than more. The folks don't have what they need to be healthy. Okay. Great sites, great ways for us to advocate and amplify. Oh my goodness, if we were in person, June Stark and company would be going, Ellen, it's almost time. All right, I'm moving quickly. You knew I was going to say something about this, right? We have to continue to heed our professional obligations, and why case managers will never be eliminated and removed by AI. We won't be replaced by it. Our processes may be enhanced by it, but we will not and cannot allow ourselves to be replaced. The case management process, developed by my amazing friends, Hussein Tahan, Suzanne Powell, continues to define how we step in and look at and engage and assess and mitigate risks, and then monitor and follow up and, yes, do our outcomes. Each step is about intentionality, critical thinking, and all that comes with it, and not simply pulling from your AI platform.
Mm-hmm.
We have to just stop the Department of Education from advancing this programming. I was hoping that I would have more about this for you, but for this point, for nursing, you can go on to these sites. Nursing still is kind of monitoring this very closely, as is social work. Once we have the public forum comment link, I know CMSA and the other professional associations will get it out to you. We are all professionals. End of that discussion. I know, there goes Jean. All right, here's how you stay informed, all right? Again, you'll have access to all of these slides, all the new CMI innovation models. CMSA's Public Policy Committee is doing outstanding emerging work. The 1115 waiver tracker, folks always ask me, how do I find out more? That link takes you directly to them. Medicaid expansion, we didn't really talk about that today, but there's a lot of shifting of those state to state regulations. Also, the Kaiser Family Foundation, Peterson, is tracking that, and the Medicare Rights Center. Wait, I got one more. I'm sorry, Jean. And then I got a whole bunch. I'm fine. Okay, good. Because this is a really important slide. And I know I'm giving you a lot because so much of this keeps shifting, right? So this impacts, and my apologies to others across the US in other states, but this is a CMS in New England. So they got the state links directly for Connecticut, Maine, Massachusetts, New Hampshire, and Rhode Island, and Vermont. All right. Eligibility overall, you can go to the FDA site, and that is there. It really provides some nice thorough charts and information that you can download or print so that you can even follow. And it's shifting. Food waivers and restrictions, same things from the USDA site. The work requirements, also from the USDA, the SNAP requirements. These are the sites. Social workers, case managers, social workers, our whole interprofessional workforce. We have our hands tied when we don't use the resources out there. And I know we're moving fast, which is so cool that this whole education program has been put up to provide you resources. So we're providing as many as we have at our disposal, but no, they are continuing to shift. And I know the chapter is really prioritizing getting you them as that happens. I made it in my time. There you go. I want to thank everybody enough. I can't thank everybody enough. Rather, see, I'm going so fast. There goes my mouth moving faster than my brain. But it's a lot of information. You guys know I provide a lot of information. I also know there are questions and comments. I am happy to stay on. I'm gonna start looking in the chat and yeah. That's it all. And I don't know what's changed while we've been done, but there you have it.
Ellen,